Hello, I am Misty Kothari, a DMP candidate at Maryville University. I will be presenting a quality improvement project about the implementation of an evidence-based violence screening tool in triage of the emergency department. I would like to extend my gratitude to the DMP committee, my chair, Dr. Maria Snell, and a second reader, Dr. Rita Wunderlich, who provided support and guidance throughout the entirety of my project. Also, I would like to thank my community member, Karen Lanesti, who is the patient safety specialist at the organization that sponsored my scholarly project and who helped make my project possible. As workplace violence increased by 23% over the last several years, reaching epidemic levels, the emergency department was found to have the highest risk of violence within healthcare systems. This significant increase has caused ED nurses to become vulnerable victims in their working environment, creating unwarranted fear and stress. Workplace violence has been highlighted as a significant worldwide issue on the news and social media. Research has proven that workplace violence can be prevented. Measures must be taken to prevent violence, such as utilizing a risk assessment tool. Although various risk assessment tools have been developed specifically for the ED, only the STAMP framework has been found effective for the early identification of violent behavior. STAMP stands for staring, tone and volume of voice, assertiveness, mumbling, and pacing. The planned project discovered how implementing the STAMP risk assessment tool in the ED of the scholarly project site compared to no intervention affected the incidence of violence towards ED nurses. Because listeners may need to be acquainted with the terminology used in this presentation, the following definitions are provided to encourage understanding. Violence, as defined by the World Health Organization, is the intentional use of physical or mental injury, death, or exclusion. Violence may be physical or psychological, including bullying, humiliation, destruction of objects, assault, and robbery. Workplace violence is defined as any verbal abuse or physical attack that occurs in the workplace, which could lead to psychological harm or physical injury. An evidence-based screening tool is defined as a validated, predictive risk evaluation tool. And triage is defined as an area in the emergency department that has been identified as a setting where the risk of violence is higher than in any other health department. 3 themes were identified after reviewing 14 articles. This included risk factors for violence in the emergency department, potential barriers and gaps in implementing violence prevention measures, and validity and/or reliability of screening tools for violence. These themes were chosen due to providing the most support and direction for the scholarly project to implement an evidence-based screening tool for violence in triage. By identifying the most common risks of violence and the potential barriers early on, this project was pursued effectively to support the validity and reliability of utilizing an evidence-based screening tool for violence. Lewin's force field analysis theory best fits the phenomenon of interest. This framework uses 3 phases as a change model to view change by itemizing, discussing, and assessing various drives for the proposed change or against the proposed change. For any change to transpire, Lewin explains that multiple types of learning must occur for process betterment. This means what someone has learned previously must be rejected and replaced with new learning. Change ensues in learning through cognitive knowledge, motivation, group ideology, and self-control. This would be considered the first or unfreeze phase, as ED nurses already accepted that change was necessary. Other methods and processes than what was already implemented had to be considered due to the continuation of violence and the need to change the department's culture. Lewin's change theory helps create this change within organizations with evidence-based translations. An evidence-based violence screening tool in triage would support this theory by providing a new means to assess patients for potential violence, which could be considered the moving phase or second phase. It was necessary to provide evidence-based research based on the STAMP screening tool and show others how this proposal would benefit them as individuals and benefit the organization. When the changes were embraced and the proposed screening tool was consistently implemented, the third phase was reached, or the refreezing phase. During this phase, the STAMP screening tool was expected to help institutionalize the changes by proving that violence screening during triage would reduce the risk of harm to ED nurses by raising their awareness of the potential of violence. By navigating through Lewin's transitional phases, it was possible to bridge the skill gap by balancing adequate communication and staff participation and providing proper training to adapt to this change permanently and successfully. However, without thoroughly completing each phase of Lewin's force field analysis theory and experiencing the relearning methods, the violence screening tool to prevent violence towards ED nurses would only become a temporary process. This would allow the status quo of the department to revert to not having any violence prevention measures in place again. The Doctor of Nursing Practice Scholarly Project was conducted to improve clinical care and patient outcomes within the ED of the Academic Medical Center. The Plan, Do, Study, Act approach of investigating and acting on the found problem was performed as a QI initiative by assessing patient violence toward ED nurses. Utilizing the STAMP screening tool to address this problem evaluated the improvement with its utilization in triage. After the implementation of the QI intervention and data was collected, it was analyzed to determine if this project proved better outcomes. If so, the department would determine how to sustain the changed practice to continue to identify patients with a potentially increased risk for violence in the ED. This project was conducted in the triage area of a 60-bed emergency department at a community hospital in the Mid-Atlantic region in the United States. The sample included active participants in the study consisting of ED triage nurses. These specific nurses engaged in the project by collecting anonymized data on their perceptions of using the STAMP tool to predict the potentially violent behavior of patients in triage. This number consisted of 83 ED nurses that were permitted to triage patients in triage out of 100 total ED nurses. In addition, the rate of violent events in the chosen ED was also collected in the pre-implementation timeframe from August 15, 2023 to October 14, 2023, and the post-implementation timeframe from November 1, 2023 to January 1, 2024. The rate of violent events during the project's timeframe was retrieved from a database collected by the chosen facility. A step-by-step outline of the project's protocol is as follows. Step 1. Educational material and data regarding violence in the ED was provided during the August 2023 staff meeting to inform staff of the implementation project. Step 2. The ED education and management team provided this researcher with a list of ED nurses permitted to participate in this quality improvement project. Step 3. Data collection from August 15th to October 14th, 2023 was collected by the safety nurse specialist regarding the number of violent events before implementing the STAMP assessment. Step 4. From November 1st, 2023 until January 1st, 2024, a paper format of the STAMP screening tool from the public domain was provided by this author and collected in triage by voluntary participation. Step 5. The safety nurse specialist provided this author with the numerical data regarding the number of violent events from November 1st, 2023 to January 1st, 2024 after implementing the violence screening tool in triage. And Step 6. Numerical data obtained post-implementation was compared to the pre-implementation data by performing a Z-test. This is an example of the paper format of the STAMP screening tool used that was adapted from violence risk assessment tools by the National Institute for Occupational Safety and Health in the public domain. In regards to the sample, a consecutive inclusion and exclusion process was continued until the implementation timeline was complete. Inclusion criteria for nurses allow the triage patients included that the participant must be 18 years of age or older, have an active registered nurse license in the state of Maryland, be employed at Johns Hopkins Baby Medical Center, Be assigned to only work in the emergency department. Have practiced as a registered nurse for 2 years in any emergency department. Have completed 48 hours of triage training provided by the emergency department. And has completed training on the use of the stamp tool. The exclusion criteria for nurses allowed to triage patients include that the participant must not be younger than 18 years of age, have a registered nurse license that is not active in the state of Maryland, be employed outside of Johns Hopkins Bayview Medical Center, be assigned to work in other units outside the emergency department, such as float nurses or those who pick up time in the emergency department, if they have practiced as a registered nurse in any emergency department for less than 2 years, and if they completed less than 48 hours of triage training provided by the emergency department. The inclusion criteria for the violent event to be calculated into the rate include: the violent event must have occurred during the project's time frame from August 15th, 2023 to January 1st, 2024. The violent event must have taken place in the chosen ED at the facility, and the violent event must have involved adult patients 18 years of age or older. Exclusion criteria for the rate of violent events to be excluded from the calculation of the rate of violent events include: the violent event did not occur during the project's time frame, the violent event did not take place in the chosen ED, and the violent event involved adolescents, children, or visitors of the facility. A sample size of at least 30 patients was needed to provide an effect of 0.5 to 0.1, with a significance of 0.05 and a power of 0.8. The sample size of this study exceeded the minimum amount needed for the study. A large sample size was required to signify the data points best to ensure consistency and reliability. The intervention model of time series analysis was utilized to study how an event can change the data. This can be best explained by the collected data within the specific periods of pre- and post-implementation to demonstrate the degree of variability. The pre-intervention data collected from the safety nurse specialist included 7,941 total patients that entered through triage, with 97 violent events that occurred. The post-intervention data had 8,464 patients that entered through triage, with a total of 70 violent events. Microsoft Excel was used for the statistical program to analyze the data. Because the data analysis determined how often violent rates occurred before and after using the stamp screening tool, descriptive statistics was used to measure the frequency of occurrence. The independent variable of utilizing the stamp screening tool was expected to influence the dependent variable, violent events. Measurements were performed with a nominal scale, since the categorical variables have no intrinsic ordering involvement. The z-test for the difference of two proportions was used to analyze the rate of violence prior to stamp implementation and after implementation with an unknown population variance. A priori analysis was completed, resulting in the suggested sample size of at least 30 patients. The ratio data from the safety nurse specialist was placed into SPSS as demonstrated in tables 2 and 3 to evaluate the statistical significance of the pre- and post-intervention period using a z-test of the difference of two proportions. The confidence interval suggested the actual change because there was sufficient information to indicate a decrease in the ratio from pre- to post-implementation, indicating the stability of the study. This means that with the use of the violence risk assessment tool, fewer violent events occurred, accepting the alternative hypothesis. Since 0 was not included in the interval, we have significant evidence to show that there was a change in one direction, as shown in tables 2 and 3. The study was considered high in strength, detecting a true effect because the achieved power is 0.8. This bar graph demonstrates the number of violent events in the pre- and post-implementation phases. From August 15th to September 14th, there was a total of 42 violent events, and from September 15th to October 14th, there was a total of 48 violent events, totaling 90 violent events in the pre-implementation phase. This is compared to the 70 total violent events after the stamp screening tool was utilized. A few limitations were identified throughout the project process. At the beginning of project implementation, 83 ED nurses were permitted to triage patients. Between November 1st, 2023 and January 1st, 2024, additional nurses who needed to be more knowledgeable about the project process were assigned to triage, such as travel and agency nurses. Although there was no way to change the schedule relating to the nurses assigned to this area, an attempt was made to educate others by personally meeting with them or by email. This limitation may have impacted the interpretation of results due to a lack of educational intervention. Another limitation was the possibility of skewed results if full participation in the study was not achieved and violent events were not adequately reported. Although we could determine the number of violent events compared to the number of stamped screening tools completed, there was not enough evidence to determine if every violent event was reported, possibly influencing results. Participation was voluntary, therefore, it was not mandated to complete the screening tool, leading to the possible lack of data collection. The stamped screening tool on a paper format, without any patient or staff identifiers, allowed for a sufficient and relatively quick way to determine if someone poses a risk for violence. However, another limitation is that these documents could have been easily lost, mishandled, or damaged during the completion process until collected by the researcher. A less efficacious barrier included the means for data retrieval. Since violent events were reported to the database selected by the organization and provided by the safety nurse specialist, it was challenging to collect data in real time. The researcher had to collaborate with another party to gather necessary analyzed data based on when the safety nurse specialist could provide the information. Although this did not become problematic, it created minor limitations during completing pre- and post-implementation analysis. Lastly, another barrier revealed that the inadequate investigation of the root cause of the safety problem led to increased patient violence. Although a screening tool for violence could be easily implemented in triage, a thorough evaluation of the causes of violence should have been analyzed, including those staff members who are directly involved in the triage process. It can be argued from the data collection that utilizing a violence risk assessment tool helped identify patients with the potential of violence, but this is only a band-aid to protect ED nurses from harm. The larger picture that creates and leads to these problematic instances must be dissected to determine what can be done to prevent such acts of violence. The results of this project were consistent with other studies indicating that a violence screening tool in triage of the ED is beneficial in the early recognition of violent behaviors. The evidence from the literature correlates to the findings of decreasing the rate of violent events by utilizing the stamped screening tool. The conclusion drawn from the project's results is that, in combination with educating ED staff about how to explicate the components of observable behavior that indicate a potential for violence in patients, the stamped screening tool, when used in triage, will decrease the prevalence of violence. The ED staff in triage benefited significantly by feeling safer in their working environment when this risk assessment tool was used. This displays the project's value in appropriately identifying those patients at risk and enhancing the transparency of this risk to the ED staff. Hence, the staff were able to observe the potential for violence early on in the triage process to implement further safety measures. The primary goal toward achieving positive outcomes was to promote safety in the ED by adhering to the use of the stamped screening tool in triage. An unexpected observation was the increased vigilance of ED triage staff who were prepared for further intervention by incorporating de-escalation techniques taught through required organizational training. Combined with the stamped screening tool, these actions help curtail developing situations successfully. A potential cause for the observed differences was the duration of the implementation period. The limited data collection timeframe prevented sufficient time to observe a true influence during the post-implementation period. Additionally, categorizing the reported behaviors during and after the data collection would have helped the researcher draw inferences about the precursors of the reported violent behaviors compared to direct observations. Without this information available, it was arduous to determine if what was observed by the ED triage nurses aligned with the reported violent behaviors. To decrease violence in clinical practice, healthcare must take advantage of research supporting the development and use of violence screening tools. Continuing to utilize the risk assessment tool in triage would be imperative to impact change, and consistency would be created by reducing potential safety gaps, leading to a method for standardizing care in the emergency department. This project contributes to future research as insufficient evidence has been shown that utilizing the STAMP screening tool in other healthcare environments is effective, as well as a lack of data to conclude the predictive capacity, acceptability, feasibility, and usability of other existing tools in ED settings. Because of this, steps should be taken to ensure a strong implementation strategy to maximize uptake. There is little evidence of high quality that evaluates the theory of current violence risk assessment tools used in the ED setting. However, since multiple tools exist and studies evaluating their effectiveness have been published more recently, this indicates that the issue is gaining more attention. It would be essential to determine which violence risk assessment tool would be most effective in predicting and preventing violence in the specific clinical environment. However, more literature is needed to support choosing one tool over another, though the STAMP screening tool was specifically made for the ED. A critical component of any QI initiative is cultural change. However, changing culture is not facile, and it is necessary to include stakeholders in the process with discussion and deliberation, education, and the development of a shared vision, along with a commitment to work together to improve safety outcomes. A call for attention must be given to the root of the problem leading to violence and triage to change ED leadership's viewpoints. The benefits of this project must be elucidated to influence the stakeholder support and patron changes to the current safety policies and procedures. The project results demonstrates the significance of utilizing a violence risk assessment tool in triage, which is essential to developing healthcare policy supporting this research. To influence and inform healthcare policy, stakeholders must be convinced that the project's hypothesis was successful and be provided a transparent context for further implementation. To continue to care for patients safely, emphasis needs to be placed on the safety of ED nurses to prevent emotional, mental, and physical harm. Therefore, a framework for violence prevention is necessary. ED nurses can be affected by repeated exposure to violence, leading to injuries, disability, morbidity, and mortality within the department. Research has found that the early identification of violence by the use of the STAMP screening tool, paired with early de-escalation interventions, reduces the advancement of a violent event, decreasing the risk of injury to ED nurses. This project contributes to the supporting evidence by demonstrating that adherence to the STAMP screening tool, when used in triage, is deemed effective, efficient, equitable, and able to be used in a timely manner to promote safety in the ED setting. Workplace violence is unfortunately viewed as a normalized part of ED nursing, as it is highly prevalent and underreported. However, evidence-based studies have demonstrated the positive influence that the STAMP screening tool has on identifying patients who have a potential for violence, specifically in the ED. The results of this project's data analysis has exhibited this by determining that the decrease in the ratio from pre to post implementation proved a change in one direction, demonstrating fewer violent events when using the STAMP risk assessment tool. In combination with violence education, de-escalation, training, and appropriate reporting of violent events, this DNP scholarly project has proved that a safer working environment can be created for ED nurses. However, future research is needed to further the generalizability of violence risk assessment tools in healthcare settings, support the expansion of violence prevention in the future, and influence healthcare policy change. Thank you for your time and attention. I will now open the floor to your questions with reference slides to follow.